So we come to our first plenary, and pleased to introduce to you our plenary speaker, Professor Brian Chung. Brian is a clinical associate professor of the Department of Paediatrics and Adolescent Medicine, School of Medicine, LKS, Faculty of Medicine, University of Hong Kong. He's obviously a geneticist from the topic that you can see, all right? So Brian has been actually designated as the Chief Scientific Officer at the Hong Kong Genome Institute and has been overseeing research developments for the Hong Kong Genome Project. This has been going on for quite some time. He was also the founding fellow of the subspecialty of genetics and genomics related to pediatrics of the Hong Kong Academy of Medicine. So indeed, we have with us somebody who is right in the middle of this. And we look forward to you, Brian, to teaching us a little bit more, exciting us. Welcome, Brian.
Thank you very much for the kind introduction. First of all, thanks the organizing committee, including Professor Joseph, Dr. Chan, and also Karen for your invitation. It's always nice to visit Singapore, a very beautiful place. That this is already the second time I'm here in the summer. I'm clinical geneticist, and I'm also a pediatrician. I'm not a bioethicist. But Professor Joseph says that, yes, you can come. Perhaps I would use this as an example of genomics and precision medicine to examine how in Hong Kong we deal with ethical aspects of genomics and genetic project in general. First of all, I'm going to introduce the project. So it all started in the year 2017 that the chief executive of Hong Kong actually thinks that it's time to make good use of the new technology, especially in genomics, for better public health policies and clinical outcomes. And therefore, a steering committee has been set up to study on the strategies for the development of genomic medicine in Hong Kong. So they have given 8 big recommendations, and one of them is actually to do a city-wide genome project. So a strategic plan of 3 years was drawn, and we want to focus on 4 strategic areas. One is to integrate genomic medicine into clinical practice. The other is to advance research in genomic science, and in the process, we hope to nurture talents in the field and also to enhance public literacy and engagement. So the institute was set up in the year 2021, and it is actually the first large-scale genome sequencing project in Hong Kong. And our aim is to do 40,000 to 50,000 genomes in 5 years. And I'm very glad to let you know that we have already completed the recruitment of our pilot phase, and we are now in the main phase. In the main phase, we have 3 themes. First, undiagnosed diseases. Second, hereditary cancers, and third, genomics and precision health. So the project was coordinated by the Health Bureau of the Hong Kong government as well as the Hong Kong Genome Institute, and we collaborate with major stakeholders in Hong Kong to implement the project. And they include the Department of Health, the hospital authority that takes care of all public hospitals in Hong Kong, and the 2 medical schools in Hong Kong. In the pilot phase, we have set up 3 partnering centers, one in the Hong Kong Children's Hospital, the other in Queen Mary Hospital and Prince of Wales Hospitals. And in this year, we have added 3 hospitals into our referring network. Therefore, now in 6 major hospitals in Hong Kong, we are now recruiting patients into the Hong Kong Genome Project. When we designed the project, we make a lot of reference to the patient journey. So we work very closely with the hospitals. We put a lot of emphasis in designing our informed consent. And of course, we place a lot of effort in setting up the right science to do this project. And one key features of this project is we returned the research reports to the patients as well as the clinicians to facilitate personalized treatment and follow-up. So we use whole genome sequencing. So this is just a slide showing you the comparison of the size of the data that we're dealing with. Sanger sequencing is a very traditional way of looking into the molecular changes in our patient, and is still a very popular technology being used in molecular laboratory in the hospitals. Whole exome and genome sequencing are both next generation sequencing techniques, but exome sequencing only look at the protein coding part, the exons of the genome, and therefore it's only 2% of the size of whole genome sequencing. So every day, these two machines in the Hong Kong Genome Institute are working on genomes that we are recruiting from the patients, and we are now having a capacities of sequencing around 300 genomes per week. So typically for one genome data set, there are around 3 million variants that we would have to look into to see which one or two of these variants is actually explaining what we are seeing in the patient. So the genome curators in the Hong Kong Genome Institute use a phenotype-driven method based on human phenotype ontology terms, and then we use evidence-based gene panel and rules set up by professional bodies in order to do that a process that we call variant prioritizations and classification. We make good use of the multidisciplinary team meetings to take care of the most difficult cases. And it's not just the clinicians, the scientists, the bioinformaticians, but also the genetic counselors and the others who have taken care of these patients that would join this multidisciplinary team meeting and give a lot of advices on how to classify the variants and how to manage the patient subsequently. So this is funded by the government, so this is public money. So the government has actually commissioned a team to independently evaluate the Hong Kong Genome Project. And NUP is the School of Public Health of the University of Hong Kong and the Public Health Genomic Foundation from Cambridge that are responsible to undertake an evaluation of the project. This evaluation is going to happen in 3 phases, and phase 1 evaluation has been completed. And Dr. Mark Crozet from Cambridge actually came in May this year to actually present the findings of the report. And I'm very glad to let you know that the project is evaluated to be fully operational despite its complexity, and has put in considerable plannings and efforts in the successful implementation despite the COVID-19 pandemic. We are very happy about this. So I'm very happy to let you know, up to now, we have recruited more than 18,000 patients and families. We have complete sequencing of 8,000 genome, and this is the data that we are now accumulating and adding up to this number every day. I think all research project would be unethical if it is not scientifically sound, and ultimately it has to be translated into some benefits of our patient. And I'm very happy to let you know that for our project, we are already seeing some successful example ending the diagnostic odysseys of patients. This is a 24-year-old lady. As you can see, the problems actually start in pediatrics. So onsets of epilepsy at 6 months, and then there are additional neurological features like dystonia, dyskinesia at the age of 7 years of age. Multiple investigation has been done in the hospital, and she remained undiagnosed. She joined our project in the year 2021, and we were able to find a disease-causing mutation in the gene SLC2A1. So this is actually GLUT1 deficiency syndrome. So in this particular syndrome, the glucose transporter at the blood-brain barrier is not functional, and therefore glucose cannot be brought into the central nervous system. The diagnosis not only end 17 years of diagnostic odysseys, but it helps us to actually improve the treatment. The standard of care is actually ketogenic diet, whereas the use of certain anti-epileptic drugs actually make the seizures deteriorate and worsen. So this lady was put on ketogenic diet for GLUT1 deficiency, and we are able to counsel her about the risk of recurrence as well as the possibilities of genetic screening in the other family members. This is another patient that I would like to show you, 13 years old, with global developmental delay and intellectual disabilities. You see multiple genetic investigations has been done, chromosome changes, chromosome microarray, MLPA, sequencing of certain genes, even exome sequencing, methylation studies, and all of these were not able to get her a diagnosis. So this actually illustrates the process that we have built in to make sure that we got actually the best chance of diagnosis for the patient. First of all, the diagnosis or the genomic analysis was performed by our genome curators. We brought it up to the clinical team, and then as a negative reports because it was not reviewing initially. And then the clinicians looks back, and then they check that actually in the notes of a clinical geneticist in their hospital, there was a suspicion of Angelman syndrome, Rett syndrome, and so on. However, the classical genes associated with these conditions are already excluded, so we work out from the gene panel that looks into conditions that are Angelman-like and Rett-like, and we adopt a new approach on the analysis of these important genes, and we were able to find a de novo CKDL5 variant that was upgradable to likely pathogenic through our discussions with multidisciplinary team meeting. So you can see this is a cooperation not only between the Hong Kong Genome Project and the clinicians taking care of the patients, but a collaborations between science and also clinical medicine. So I have done with the first part with my talk on the introduction of the project. Now I would like to go into and zero in some of the ethical aspects that we have built in the project to see how we actually tackle these issues that are important. First of all, I think all of you agreed with me that the individual-focused principles, things like autonomy, privacy, justice, these are all remains very important even in the practice of genomic medicine. However, there is some evolution within the field of genomic research and the related clinical practice. Now, we move from individual focus to community focus, now to even something we call a system-focused principles. Ethics is not static, it's dynamic, and then it's very important for us to focus on the system that is operational within which the research and the clinical practice is based. And that's why what we are doing in the Genome Project hopefully will inform the clinical practice because all these items that now we're going to discuss in a little bit of detail are important in both related to precision medicines and genomics. Governance, transparency, empowerment, right not to know, security, globalizations, all these are very important and they're interlinked with each other. And you see that sometimes one certain kind of practice actually requires some knowledge in two domains of these principles. So governance, the first principles that I would like to discuss. Governance is about to ensure the interests and the right of patients, and here we're talking about our children, are safeguarded. And the procedures and practice to safeguard our participants include experts' advice, and whether there is internal procedures and external review, and whether in the practice every day that it's compliant with all these policies. And of course, it's related to transparencies that I'm going to talk next. So when we first start the project, a focus group meeting has been done with clinicians, families, and patients in order to outline what are the important values of concerns to them. And these are some of the things that we can identify through our focus group meeting. And it is actually in alignment with findings from the literature, say from Europe or in North America. They stress that the provision of accurate simple and colloquial information is important, and this comes up in many of these discussions within our focus group. And of course, informed consent is very important. And they want transparent information, so the pros and cons should be discussed with them. And if they decided not to join or to withdraw from the project, it has to be their freedom. It has to be stress-free and not affecting their own clinical management in the hospital. And of course, they're very concerned with the data security. Some of these findings have been published, and we are going to publish a series of papers on how do we implement Hong Kong Genome Project. So this is about the running of the pilot phase, how do we do the publicity strategies, and one coming up is about setting up the laboratory procedures to drive this project. So when we developed the Hong Kong Genome Project protocol and the consent material, we actually have our own in-house ethics advisory committee that gives us a lot of advice. And within this committee, we have bioethicists, lawyers, patient groups representatives, geneticists, and so on. We follow the international standards that is outlined here. And in addition, we also sought advices from various professional bodies and personnel, including the government, Equal Opportunity Commissioner, and also the Privacy Protection Commissioner for Personal Data of Hong Kong, the medical schools, and our lawyers. And we have obtained IRB approval from the Central IRB Committee of the Hospital Authority, the 2 medical schools, as well as the Department of Health, meaning that our project now can actually recruit patients all around the hospitals within the public healthcare system in Hong Kong. So transparency is important. We have to ensure that the Hong Kong Genome Project is being carried out in an open manner so that we can harness autonomy, we can demonstrate trustworthiness, and in the process, we hope that we will be able to reduce any psychosocial impact from the uncertainty or the confusion associated with the project. And we want to facilitate the process of decision making. We think that for transparency, clear communication is the most important strategy to do that. And luckily in clinical genetics, we always talk about the process of genetic counseling. And we use genetic counseling, especially on before the testing and to obtain the process of obtaining informed consent to enhance transparency. So genetic counselors are the professionals that always serve as the bridge between patients and clinicians, participants, and scientific project. In this project, instead of making use of, say, a research assistant, we emphasize that all recruitment would be done by genetic counselors. And genetic counselors in our team help to explain to patients to make these information more easily understandable. And then we provide them with age-appropriate information in order to guide them to make informed consent. We allow them as much time as possible for them as they need so that they can think about the process and make the right decision for themselves. And then in the process, we also see them to explain and address all the needs and expectations and to provide the necessary psychosocial support. So to help our genetic counselors in recruitment, we have created several types of participant-specific multimedia information. So we have written information. So the written information are provided in an age-specific context. So we have information booklet for adult participants. And we also have a version for our young participants, and you can see here, we also developed some souvenirs for them, like the stickers, which the kids all love them, all right? Although the mother always complained that all the drawers and the cupboards and the fridge are with all these stickers around their home after they have joined our project. But kids actually love all these information materials. We also did some videos, a set for adult participants and a set of animations for our pediatric participants in order to help them to understand about the project and to give them some knowledge about genomics and genomic medicine. And I have prepared one video to show here.
我哋嘅身體入面有無數嘅 DNA 代碼。 佢哋就好似一塊塊好細嘅拼圖，砌埋一齊，成為一幅大拼圖，從而組成身體唔同嘅部分。呢幅大拼圖就係我哋所講嘅基因組。每個人嘅大拼圖都唔一樣，而拼圖嘅唔同排列唔單止決定我哋嘅身體特徵， 例如係咪戴眼睛或者亂頭髮，仲會話俾我哋知關於健康嘅重要資訊，同埋點解我哋會唔舒服。只要集齊呢一啲拼圖，我哋就可以解開身體嘅奧秘。世界上有啲小朋友患咗唔常見嘅疾病，一直揾唔到患病嘅原因；亦有啲小朋友好細個就患上癌症，令到佢哋同屋企人都唔知點算好。所以我哋集合咗好多醫生同科學家，成立咗香港基因組中心。我哋希望邀請你同屋企人一齊參加呢一個香港基因組計劃，等我哋試下幫你揾出身體唔舒服嘅原因，同埋幫你揾到更合適同有效嘅治療方法。首先，我哋希望揾到以下2類患病嘅小朋友。第一類係唔舒服，但一直揾唔到病因，而病症可能同遺傳有關。第二類係患有可能由遺傳引起嘅癌症。除此之外，我哋都希望邀請到以上2類小朋友嘅屋企人參加。只要你係剛才所講嘅2類病人之一，你同你嘅屋企人就可以一齊參加呢個計劃啦。醫生會將你提供嘅基因組拼圖放大，仔細研究下每一塊拼圖嘅排列。如果拼圖砌錯咗，就會令到身體唔舒服。呢個時候就要揾出擺錯咗嘅拼圖，就好似玩緊找不同遊戲咁。我哋希望透過呢個計劃，幫你揾出身體唔舒服嘅原因，等你可以得到更有效嘅治療，同時幫助到其他有相似病徵嘅病人，為相關嘅醫學研究提供重要參考。想知多啲？歡迎你同屋企人一齊瀏覽呢個網站，亦都可以向計劃團隊查詢。
Thank you. I specifically choose a Cantonese video because I want to let you know that this is tailor-made for the populations in Hong Kong. Of course, we can find a lot of educational material in YouTube, but it's very important to develop your own because then kids won't be able to understand these in English if they are studying in the local school, and perhaps this will facilitate and get them interest in the project at least. So the 4 cute little guys are the TCAGs, the 4 nucleotides of the genome, and they are actually the people, instead of us, guiding the kids through the project, through the recruitment process of the Hong Kong Genome Project. And I think good communication is also very important for the third principle that I'm going to illustrate, the empowerment. It is very important to let kids know that they have the rights to control about their own health and their quality of life as they grow out. So we have a very good discussions in the first lecture about the decision making, the shared decision making. And many times parents are actually providing proxy consents for the best interests of the children. And you see that this themes also is very important in genomic medicine. But we feel that as the child was growing older and older, becoming more mature, they have the rights to receive the appropriate guidance to empower them, to have greater control over their health. And then they should be increasingly get involved in the process of consent in order to maximize their autonomy. So we want to show that this project actually respect these young participants in joining the project. So the ethical principles that we use in the Hong Kong Genome Project are the following. Participant is completely voluntary, and they can withdraw anytime without providing a reason. And the participation or withdrawal will not affect their rights to receive routine medical cares in the hospitals, and they can ask as many questions they like and take as much time they need to decide on the participation. So we use this 3-tier modeling in our consent and assent process. First of all, we have an assent information package that I have already shown you that actually aim to provide information appropriate for participant age 12 to 17 years of age. We also include this particular category of our participants of 16 to 17 years of age that actually in the informed consent, it needs to be co-signed by the parents as well as the participant himself or herself, in order to recognize their role in making the decision in joining the Hong Kong Genome Project. So for those participants aged 16 to 17 who can sufficiently understand the project, they need to co-sign the consent form with the parents. So this is the design of the consent form. Now we go electronic. We have an e-consent form within the clinical front end of our system to facilitate the process, but the design is similar. They need, if it is a 16 to 17 years old, signatures needs to be collected by both the parents as well as the participants in order for them to join the project. Reconsenting is also very important when the young participants reach the age of 18 years old. A reconsent process will be initiated by our partnering centers. So the genetic counselors will actually make contact and then re-explain the situation, the consent process to them, and then they would need to do the reconsents in order for them to stay in the Hong Kong Genome Project. Now I want to talk about the right not to know. So this is very important because in our analysis, of course, there is a primary indication for doing the genome sequencing. Global developmental delay, difficult to control seizures. So the primary analysis will be aiming towards the detections of genetic changes that may explain the primary reason why a certain participant joined into the project. But since we have the capabilities to read the whole genome, a lot of different genome projects around the world make good use of this opportunity to look into secondary findings. These secondary findings may actually reveal some health concerns of the patients that is not related to the primary situation, and they may actually be at the stage of being asymptomatic, and scientific evidence has been there to show earlier detection may actually help to alleviate these healthcare problems. All right. However, this concept of every information must be disclosed is no longer something that we would consider appropriate without the patient's agreement. We actually respect the right, especially for children, to have an open future by saving the decision making until they're mature enough to make the best interest out of their own. So when we design on this secondary findings of the project, first of all, we only choose onto those conditions that has the highest, strongest scientific evidence that these conditions, if you know early, have good impact on health. All right. So this is the 13 gene list that we choose to work on for our additional finding. Second of all, we also divide them into adult onset and pediatric onset conditions. And for children, even if their parents or themselves choose to know about these additional findings, we would look into the age of that individuals in order to make that decision. So when we choose these genes to be included, we always look into the scientific evidence. So for example, this Kaplan-Meier curve is showing you about why we want to know whether a child is affected with a mutations of a familial hypercholesterolemia, because evidence has been there to show that they have better health outcomes compared to their parents who do not know that actually they have this familial mutation. So this is about the right not to know. I know that I'm running out of time, so this is the second last principle that I would like to illustrate is about data security. It's always a balance between the information that you need to collect in order to facilitate the research and also the right of protection of the privacy and the security. So in Hong Kong, there are clear guidelines that genome data is considered a form of biometric data. So it's actually under the protection of the law in Hong Kong called the Personal Data Privacy Ordinance. And so there are 6 different data protection principles that actually apply not only to the clinical information that we are collecting, but also to the genomic data we are collecting. I'm very happy to let you know that earlier this year, we actually received this Golden Awards, the Privacy Friendly Awards for the year 2023, because actually we have satisfied a certain standard as actually laid out by the Office of the Privacy Commissioner for Personal Data of Hong Kong. So very quickly, these are some of the data protection measures that we applied, not only to pediatric, but also to our adult participants. We have a strong governance. So we have in addition to our Ethics Advisory Committee, we have our Data Advisory Committee to advise us on the policies and the best interest for data protection. So we de-identified and we encrypt all personal and genomic data, not only when they're static, but also when they're dynamic, when they're transferring from one place to the other. So we have a very secure data access control system. So people will have a role-based data access, and they can only access data in a need-to-know basis. So we are very transparent in our data handling practice. So all these practice and our policies are available in our guidelines and in our informed consent package. And we have regular audits, both internal and also external. We employed a company called Deloitte to do the privacy data compliance assessment regularly. The last thing is globalization, and I think this is always the ultimate goal, that genome projects around the world, the Singaporean 100K Genome Project, the UK Genomic England Project, and perhaps Hong Kong can talk to each other. The interoperability will enhance the effectiveness of data sharing. And also the practice, the good practice, like the mutual recognitions of the ethics reviews and oversights, will be something that we can work together globally. So in order to do that, we also make good use of different opportunities to talk to our international collaborators, stakeholders around the world. And we were invited last year to join the Thought Leadership Theme Series of the American Society of Human Genetics, the biggest meeting every year in North America, the biggest human genetics meeting. And in this video, we have support from the Health Bureau of Hong Kong. Our Secretary for Health was there, myself, my colleagues, as well as 2 summer interns. One is a medical student who would like to be a clinical geneticist, and the other a science student who is actually having a dream of becoming a genetic counselor, joining and talking about their experience in our institute. And I have prepared a 1-minute version for your viewing here.
We see genomic medicine as a key to a healthier future for Hong Kong. So the government decided to set up Hong Kong Genome Institute.
We were established with the mission to accelerate the integration of genomics into medicine by driving clinical application, advancing research, nurturing talents, and enhancing genomic literacy. As our first strategic move, we rolled out the Hong Kong Genome Project in July 2021.
Clinicians, scientists, geneticists, and genetic counselors can work together to develop this new discipline in medicine. We aim to recruit 20,000 participants to learn from their genome data.
We see genetic counseling as an effective patient engagement process to enhance understanding among all age groups.
Hong Kong Genome Project can contribute to the diversity of human genomic data. This can be translated into health benefits for millions of people.
Hopefully this video shows you a bit about Hong Kong and the Institute and the work that we're doing there. I think the unique advantage of our project is that we will build the genomic database that is reflective of the Hong Kong population. We would concentrate people with different expertise in genomics and genomic medicine to work together to a common goal. And through that, we can actually establish an infrastructure to deliver it. So this is still the only and the first patient-to-patient whole genome sequencing workflow that is now happening in Hong Kong. So this is my last slide. Once again, thank you very much for your attention. Hopefully this would provide an example of how we do an ethically sound precision medicine project in Hong Kong. Thank you very much for your kind attention.
Thank you, Brian, and congratulations on the tremendous work that you have been doing. We have some time for questions, And yes, from there, Huilin.
Hi, Professor Brian. Thank you so much for your excellent lecture, and it was really interesting to hear about the progress that this is being done in Hong Kong. My name is Hui Lin. I am a pediatrician and clinical geneticist at the National University Hospital. It's really nice to meet you. I had two questions. The first is about secondary findings. So for participants who had consented to disclosure for secondary findings, especially pediatric patients where the secondary findings may be adult onset, later onset, or never onset, how do we support these patients through the psychological burden of such an information? My second question is a little bit tangential to this, and it's about genomic newborn screening. I would love to hear your thoughts about that. Thank you.
Thank you. I'm so glad that we have colleagues practicing clinical genetics here among the audience. I think these two are very important issues. You see that our list is actually very short. We do not use the American College of Medical Genetics and Genomics because their list is keep on growing. We make a good reference to what our colleagues in UK are doing, and they actually prefer the much shorter list. And you can see that we are not calling it incidental finding, but secondary, because we do not report them when we incidentally see them. We actually make an effort to look at this 13 genes that is included in the list that is shown here. It's also there in the web page. So we have an active way of looking into that. In the process of guiding the pre-test genetic counseling, you remember that we have a series of videos, both for adults participants as well as the young participants. And one video is actually designated towards that purpose. So there's a whole video that talks about how we deal with additional findings. First of all, this is unrelated to the primary findings. Second of all, they are expected to receive this information much later, because obviously we would like to spend our effort in looking into genetic changes that is associated with the primary indication first, and then this additional findings. And in our design, we also divided that 13 conditions or 13 genes into adult onset and pediatric conditions. So for kids, participant, for example, 5 years old, we would only look into those that are pediatric onset. Unless when we are about to issue the reports and when we are doing the reconsent, they have reached the age, then we would expand the secondary analysis to include also those adult onset condition. And of course, in the process of reconsenting, it would be the person from a child becoming an adult making the decision. They can always give this decision, hey, I'm not interested in receiving any additional finding at all. So this is how we actually work on this. What we are also doing now is to set up an evaluation part of the Hong Kong Genome Project. So we evaluate on the psycho, social, and economic outcome. Clinical outcome, obviously, we can capture quite easily with our partnerships with the hospitals, because they will be telling us whether they can confirm the finding in the clinical labs, in the post-test genetic counseling sessions, whether this can be translated into a better clinical management. But we feel that there's a lot of information that we need to capture with such a large-scale project on the psychological well-being, on the social part, as well as the health economic part. So we decided to actually start the project first. I was given in year 2021 4 months to start the project. So I started working in March 2021, and I recruit the first patient in July. So therefore, we have to set up things in block. Right now, we are working on the outcome evaluation. And the reason why I'm bringing this out is additional finding would be a major area that we would like to capture to see if it is really helpful in terms of the clinical outcome, as well as does it cause any stress emotionally, psychologically to these participants. So these will be very interesting information and data that I hope I will be able to share later. About newborn genome sequencing, I think this is really something that is very popular, because 4 days later, I'm going to Tokyo to join the same meeting you're going to. They're asking me to give a talk actually on this. I think the two aspects, diagnostic and screening. And I think it's proven beyond doubt that newborn genome sequencing as a diagnostic tool is very useful. And as a matter of fact, I have done a little survey actually from the first research paper publication to this application as a clinical service in some country is actually taking less than 10 years. So from research to clinical practice, less than 10 years. This is most amazing because if you look into major scientific discovery and how they put into the clinical practice, typically is 15 year to 20 years journey. This is less than 10 years. In countries like Australia, UK, and the States, this is already provided as a clinical service. But I think the interesting area would really be about screening. So now we're doing a lot of newborn screening, whether this is going to be working hands in hands with the other modalities. Could it actually replace some of these modalities? And about the issues of this lifetime or lifelong genome, of course, it would generate a lot more ethical issues. And when it comes into real-world practice, the ethical issues must be translated into how it will roll out, how it will appear in different cultural political systems. And I think all of us needs to do our own assignments in order to see what is our societal or system readiness, even if we know that this is potentially going to be beneficial.
Thank you.
Daniel?
I tend to answer question I know the answer longer to avoid questions that I might not know the answer. Sorry about the long answer.
Hi. Professor Chung, thank you for your wonderful presentation and congratulations for your achievement. It's really impressive work. So if I can go back to your slide 27 about the right not to know.
Okay.
We know that this is a very complex diseases, okay? On the one hand, you have a gene bank, you have more information, you have more tests to disclose to the participants. And on the other hand, you have a different age group of participants. They might change their mind through time. When they get older, they want to know more, or they refuse to know anything further. So this is actually a kind of two-way communication in the changing kind of environment. So this involves very complex genetic counseling.
That's right.
So do you provide like the expertise or people training who can really do this informed consent process and the further counseling when they know about the information and they want to know more? Yeah, because it's quite complex. If, for example, in my hospital, I'm from Taiwan, and we have TPMS, something like this. So I find this difficult, this very demanding work to fulfill the needs.
Thank you very much for your questions. We all learn from each other. For example, tomorrow I have set up some meeting to meet with my collaborators in Singapore to learn from them. And at the end of October, I'm visiting Taiwan to learn from the Taiwan genomic scientists about this. I think the process is actually more than just two-way, but it's also dynamic. The reason why I'm saying this is because I have talked about withdrawal. Actually, we are not only seeing in a very small percentage of people that there's a withdrawal. So our withdrawal rate is 0.2%. What is interesting is after withdrawal, we have re-enrollment. So there are patients who withdraw and then come back to say that we want to join the project again. So when we decide, about our withdrawal work process, actually we have to make it very clear that even after withdrawal, it's that the data would be freeze, not being analyzed further. And then there is a choice that they can ask us to erase the data. But once they erase the data, then if they have the wish of rejoining the project, then they have to start everything again. So this is how we try to build in the system, but I'm sure that would be something that we cannot foresee right now. So enrollment, we foresee this, but it still comes as a surprise because we are only 2 years, and then you can see that the dynamic nature of the decision process. So informed consent is not about signing a paper, but it's a process. That's why when we first established the workflow, we think that for some work process, we have to take it out of the hospital and do it centrally. For example, whole genome sequencing, the scientific part. But in terms of the recruitment, the pre-test genetic counseling and the post-test genetic counselings, we decided to actually work with different hospitals. Obviously, this is more complex administratively, but we think that this is the best to the patients because it's not only the genetic counselors who would be able to help, also it would be the referring clinicians. For example, for the themes of undiagnosed disease, the clinicians typically follow these patients more than many years, 5 years or 10 years. So they have that established doctor-patient relationship that would allow them to have an additional layer of effective communication in addition to what the genetic counselors are doing to handle these complexities and this dynamic nature of informed consent. And just adding to my colleagues who are also practicing in clinical genetics, the clinicians there would be able to look at this holistically because obviously, besides the Hong Kong Genome Project, there may be other clinical testing or research project that may benefit the patient. So they can manage everything holistically in an individual manner rather than, for us, in a project-based management. Thank you.
Time is up.
Okay. See, my strategy were only 2 questions, unlike our first speakers.
Yeah.